Hello, my name is Lindsey Russell, and I'm a gastroenterologist as well as a nutrition support specialist, and I specialize in short bowel syndrome and nutritional support. This course is just one in a series of modules on indirect calorimetry brought to you by Channel 1 on demand, nutrition education. This module is part 3 of 4 in the series, and we're focusing today on adults. As well, we're looking at the interpretation of results of indirect calorimetry. These are the objectives here that I'll have you read through. And today I'm going to present 2 challenging cases. I really want you to take away the approach of interpretation and application of indirect calorimetry and really recognize that it's not always clear-cut in clinical practice. Let's begin with case 1, which is a critically ill adult. So this is a 6-year-old woman with hypoxic failure that was admitted to the ICU after an aspiration event. She presented to the emergency department with abdominal pain and vomiting and an acute hypoxic respiratory failure. Of note, she has a history of tongue cancer with PEG-J and nutritional support at home through her tube feeds. Her clinical status initially, you can see here some of her vitals. Of note for indirect calorimetry specifically, her PEEP was 8 on her vent settings and FiO2 was 25%. You can see the labs here that I won't get into, but in general, her microcultures for blood were negative. Looking at her nutritional status, she did come in with a weight of 89 pounds and a BMI of 15.55. So she had also severe subcutaneous fat and muscle loss with a diagnosis of severe malnutrition. She was on a polymeric formula at home, providing about 1,800 kilocalories a day. She has underlying chronic signs of inflammation as well with this acute event. So keep that in mind about her nutritional needs. With her nutritional support plan initially, we did her dosing weight of 40.8 kilograms, and we started with a polymeric 1.5, providing about 1,650 kilocalories a day, and she was at a moderate risk of refeeding, so we did not want to advance her enteral nutrition and monitor her electrolytes closely. With the indirect calorimetry, it was valid because we had a ventilated of oxygen of 158 and ventilated CO2 of 103, and the coefficients we will get into, and a duration time of 28 minutes. Her resting energy expenditure was 1,048 kilocalories, and her respiratory quotient was 0.68. So let's work through our approach. So step 1 is I look at the validity of the test and evaluate the coefficient of variability. So her VCO2 and VO2 both were under 10%, and the time of the testing was over 5 minutes. So this is a valid test in context of her having a normal or the FiO2 at certain cutoffs as well as the PEEP. Step 2 is I look at the measured respiratory energy expenditure. So she was measuring at 1,048 kilocalories or 26 kilocalories per kg. Remember with predictive equation with the 40 to 50 kilocalories per kg, her measured is actually 75% of predicted, and her Harris-Benedict was 1,258 kilocalories or times 1.2 for sepsis, which is 84% predicted. So this highlights the accuracy of the predictive equations. So you can see those 12% or 32% respectively to her measured. So the importance of doing indirect calorimetry in this situation. Next, I looked at the RQ in the gases. So look at our RQ value was 0.68. It is within range of a valid test of 0.67 to 1.2, but you can see on the graph here that it's a sign of maybe underfeeding or high fat or ketogenic diet. In addition, her ventilated O2 is 158 and ventilated CO2 is 103, which is a little bit on the low side. So how did we apply this? So we think of the ventilated VO2 as, again, fitting in that underfeeding, maybe hypothermia, hypothyroidism, or sedative agents to review, and then decreased VCO2 and the RQ value, again, highlights a little bit of underfeeding. So how we discussed is we looked at her current EN script of 1650, given the low MRE and the RQ and the patient with the low weight, we wanted to obtain acute, accurate intakes and outtake reports, which is a whole other topic on itself in the ICU setting, and confirm that nearly 100% was being delivered. So then we adjusted her EN script, and we looked at 130% of the measured REE in the setting of post-acute critical illness phase, or 33 kilocalories per kg. In addition, for this patient, we want to consider other things of ruling out malabsorption through absorptive testing. And of course, in this scenario where it was a little bit unexpected, we wanted to repeat indirect calorimetry measurements. Unfortunately, for this case, it was challenging in the setting of severe malnutrition for the highlights and reliance of looking at the measured REE and the RQ in the setting and taking in the whole patient context. So this is someone that had severe malnutrition and active sepsis, and notably on the use of repeat measurements. So it's not always available. So in this patient, she actually deteriorated and compassionate care was initiated. So we were not available to repeat the test and see if we were meeting those targets. In addition, reliance on the vent settings at our institution where we measured this patient, we had no canopy available. So some limitations in that regard. Let's move on to case 2, which is post-critical illness. So here we have a 70-year-old gentleman with a post-lung transplant. So he had a past history of sarcoidosis. He had interstitial lung disease with a transplant about 6 months ago, and he's been in the ICU since then. He has a PEG tube present for nutritional support, and he did have some episodes of post-op sepsis treatment throughout his 6-month stay, but he remained in the ICU and it was difficulty weaning him off the vent. Let's look at his clinical status. So at the time of measurement, he was afebrile, he was stable, patients with apneic episodes overnight on volume support for his ventilated setting and tidal volume decreasing to the 260s. Notably, his labs, there was no emergent needs for dialysis, and his urine was about 300 cc's in 24 hours. Looking at his nutritional status, he was deemed to have moderate malnutrition. So his BMI is 24.35, which is in the normal range, and there's no significant changes in his weight. He was having some diarrhea at the bedside, unable to assess his functional status because of the ICU setting, some potential signs of inflammation because he's chronically ill, chronic condition, and high CRP. And in physical exam, he had mild fat loss and mild muscle loss. So this determined the moderate malnutrition on assessment. His current nutritional support plan, we did a dosing weight of 79.2 kilograms and estimated needs, again, by the 25 to 30 kilocalories per kg, was about 2,000 to 2,450. And then estimated protein needs was 1.3 to 1.7. His enteral nutrition, he was on a 2K cal formula at 45 cc's an hour, and also modulators with fiber and carb-free protein as well. So his total nutrition was about 2,295 calories and 121 grams of protein. At this point, because of the difficulty with weaning of the vent, we wanted to do indirect calorimetry to see if this regimen was appropriate. So his first indirect calorimetry that we had, he was a candidate for. His resting energy expenditure was 1,262. His respiratory quotient was 0.78. Gases are seen there, and his variability was 6 and 4 respectively, and testing duration was 27.5 minutes. So let's go through it again. Step 1, is this valid? Well, we look at the coefficients of variability. Both were under 10%, and duration of testing was 5 minutes. And this clinical context, he was equipped to meet indirect calorimetry needs. So this is a valid test. Next, I looked into the resting energy expenditure. So he was actually measuring at about 16 kilocalories per kg, and that's 63% of predicted. And even if you go with Harris Benedict, that was 80% of predicted. So he's measuring a lot, significantly lower than expected. Again, this highlights the accuracies of predictive equations and the use of indirect calorimetry to get a better assessment of the patient. When we look at his RQ status, notice that it's 0.78, which is in the range, and it's a little bit on the underfeeding range, but it's close to the optimal range, and then his gases are noted there. So the interpretation step 3, let's look at the RQ and the gases. So the VO2 was 184, which is a little bit increased, suggestive of maybe overfeeding, sepsis, and hypothermia or hyperthyroidism. So this gentleman, you look at, the results of this. So his resting energy expenditure is below predicted. His RQ value is a little bit in the middle, and some of his gases are high. So we thought that the current script of 2160 kilocalories was a little bit too much higher than him, that his needs would need. And he was overfeeding confirmed through the intake and outtake reports. So with this indirect calorimetry, we did decrease him down to about 1,600 kilocalories per kg, kilocalories per day. And still, this is about 128% of the resting energy expenditure, but this was in discussion with the dietitian team for the ICU. And of course, we want to repeat testing. So this case, we do 3 weeks later, still being fed about 1,600 kilocalories, still on a trach collar, but he's requiring the vent intermittently. So let's repeat this again. So to confirm, he was getting about 1,860 kilocalories a day with the modulators, but effectively it was around 1,600 kilocalories with the outputs. So indirect calorimetry 2 was a valid exam. This time his resting energy expenditure was 936 kilocalories per kg per day. Respiratory quotient was 0.8, and you can see the gases there. And duration of testing was 27 minutes. Here's a photo of it here that you can see that we want to grab that steady state for interpretation for the gases. So this is the best 5 minutes that the machine can have, but you can see all the numbers there. So I wanted to provide you with a picture of what it looks like clinically. So let's go through our steps. Steps 1, is this a valid exam? Yes, his VCO2 and VO2 were both under 10% and testing was over 5 minutes. Step 2, look at the measured resting energy expenditure. So this is even lower than it was before. I won't get into this today, but there could be various reasons for that. But predictive equations, this is now 63% of predicted, or 59% if you're looking at the Harris-Benedict. Then we look at the RQ value. So it's actually increased a little bit to 0.8, still within that optimal range, but some of his gases there that we'll get into, they can show that his RQ is improving, but his VCO2 is decreasing. So think of it a little bit of an overfed state. So his current prescription, about that 1680 that he was getting, confirmed through intakes and outtakes, we adjusted his prescription again down to 1,200 kilocalories per day, which is 12 kilocalories per kg, to prevent overfeeding. This was a big discussion that we had with our team, and of course close monitoring in this setting, but we decreased the amount that we were providing this patient. And then with that, subsequently, a couple of days later, he was able to wean from the ventilator and transferred to the ward. So the highlights for this case is that interpreting indirect calorimetry is not always that clear-cut textbook, and you really want to reinterpret the unexpected results, apply it to the patient in the whole patient context, and really look at the resting energy expenditure and the RQs. And think about, well, in this setting, we did wean the enteral nutrition and he was able to wean the vent. And notably, the use of the repeat measurements. This is so critical because the timing reliance on the individual and the clinical status for the patient. Some guidelines suggest that anytime you have a clinical status change, that you want to repeat the indirect calorimetry. But this can be a little bit challenging in clinical practice, that you can see that 3 weeks later, we repeated it, and that was due to staffing challenges as well. And looking at the reliance on the vet settings, again, in my institution, we don't have Canopy available. So that might be a point going forward as well for these repeat tests. So my take-home points overall is that indirect calorimetry is not always clear-cut. It's helpful to have a systematic approach for interpretation. Remember the patient at the bedside. Every patient is unique. You need to individualize. Consider the vent settings, malnutrition status, and clinical context. Repeat measurements may be helpful, and adjust your nutrition plan. It's really important to reevaluate. And with that, I would encourage you to watch the other videos regarding indirect calorimetry on Channel 1 series to learn more from my esteemed colleagues, and have a great day. Thank you so much.